Hey everybody, Chris Brown here for another Shockwave case. I'm joined by Eric Rothstein, interventional cardiologist, complex PCI operator, C2 operator at Dartmouth. He's got a really cool case for us to see today. I'm pretty excited for it. Eric, thanks for joining us, man.
Hey, thanks so much for having me. So yeah, this was a fun case that I did about a month ago. Patient's a 69-year-old teacher, and I know it's always strange in a PCI case to have echoes first,
Yeah, I don't even know what
but
this is. So,
but she's a 69-year-old woman, had breast cancer with lots of radiation back in the 90s, and did well from a cancer standpoint, but developed dyspnea and AFib when she went to Paris. Kind of ruined the trip for her. And so over in France, she had an echo done that showed that she had severe tricuspid regurgitation and radiation valvulopathy. Ends up coming back here and is referred to our structural heart team. And so initially she's screened for class 2 TR, but she screen failed. And then so she was referred down to MGH and for consideration in different trials, screen failed. She declined a referral for open surgery to fix her tricuspid valve. And then, kind of in between all of this happening, she starts getting angina. And so she goes for a cath, and she has high-grade RCA disease. The left side looked fine. And it's one of these RCAs with the anatomy that I hate, where the PDA comes off of a marginal, and it always makes trying to deal with these marginals a little bit more challenging. But my colleague took this case on. You can see here that it was a lot of challenge with trying to cross it with multiple balloons. And eventually he gives up on trying to cross it with balloons and takes a 1.5 rotabur to it. And you can see here everything's held on at least through that. Or sorry, it was balloon unexpandable, not
ooh,
balloon uncrossable.
that's
Um,
that's that's
yeah, it's a challenge.
ooh,
And so eventually, after he burrs through it and deploys two 3 millimeter stents with minimal overlap, he gets a good result. You can see there's a
yeah,
little bit of under expansion right at the takeoff of that marginal slash PDA, but overall, it's a
it's a
pretty
pretty good
impressive result
result.
for what he was
Yeah.
dealing with. Yeah. And so year goes by, she does relatively well with this until she gets hospitalized with right heart failure. And then finally, she goes and meets with one of our surgeons, gets a tricuspid valve replacement with bioprosthetic valve. He also does a maze and takes off her left atrial appendage. And after all that, she ends up well with a pacemaker, but does well. Overall for open tricuspid replacement, not bad.
Oh man, that's
So right heart recovers and she's doing well. And then, in September of this year, so she gets a year out of it and then comes back in with angina again. And you can see that the angiograms are challenged here by all the hardware now in
oh nice.
place.
Jesus.
Yeah, exactly.
Is that
You
a
know,
leadless pacemaker and a real pacemaker? Oh, look at that.
that so yes, that's exactly what it is. She had some issues with her device not capture. There are issues with some of the leads not working. I don't know, EP stuff.
Yeah.
So yes, she ends up with a micro in addition to her pacemaker. And at least the part of this that I understand better, the you could see she's developed severe ISR right at the bifurcation of that marginal and certainly above in the proximal vessel, despite the really nice result that my partner had gotten. And so this was a case of multiple trips to the cath lab, and initially ended up being a real challenge for me just to get a wire into the vessel. I was able to, initially wire into that marginal slash PDA branch using, a microcatheter. I think this is a Mamba Flex. And despite I tried to use dual lumen microcatheters, I couldn't get an angled microcatheter to deliver. But ultimately, I just kind of took the risk, ballooned it for that open sesame trick that sometimes we'll do for cap modification and a CTO at a side branch. And then using another microcatheter is able to wire it with like a Xeon Black.
Yeah, it's tight, man. Right where you want to make that turn. It's got like a backflip to it. It's
Yeah.
yeah.
Yeah. It's one of those where, another complex case, you try to just jump to other strategies. You never want to get stuck on something. And this was one where, the only way to fix it is just to wire it better. So it was frustrating to not be able to reach into the whole bag of tricks. So then this lesion ends up being especially right. The proximal lesion was fine, that wasn't an issue, but the that mid lesion right at the overlap segment of the two stents was balloon undilatable, and so my sort of first go-to for balloon uncrossables is to just do granuloplasty or balloon-assisted
I can't
micro.
believe you got a Sapphire to last to 22 atmospheres. I can't get those things above like 12 before they
No,
rupture.
if I want to do, I mean, that's pretty much the only use that I find for sapphires,
Yeah,
is for
yeah.
granuloplasty.
I just
Um,
they always break on me so much sooner than 20. I'm like cranking. Maybe I need to
I-
crank faster.
yeah, I mean, I guess the fellow got excited and really pumped that thing quickly.
I like it.
And I mean, I tend to use sapphires for this if I'm just trying to get something across. I find the Takirs to be more deliverable, even
Agreed.
though they're a larger balloon. But
Yeah.
again, that's just anecdotally what I've found. Um, and so after this, yeah, I really struggled with the lesion because, I was able to finally get a scoring balloon down. I took it to 30 atmospheres. I don't have access to ultra high pressure balloons from CIS.
No, neither do
So
we. We don't have OPNs yet either.
yeah, so I tend to just take an angiosculpt to really high pressure off label. And then I took a 3 millimeter shockwave balloon to that. I was able to deliver it after all the prep work. And that actually was unable to expand it. So then, I went to, laser contrast bombing, and just wasn't able to do anything. I think I did 12 passes through it. She tolerated it surprisingly well. I was able to get a IVUS catheter down to show that this really was a large enough caliber vessel, and that's what it looks like with a 3 millimeter balloon in, where just no expansion in that mid segment.
That's wild. It's also wild because your partner's expansion was actually not terrible,
It, yeah, it really
So,
wasn't, and
yeah.
so I took this is what the shockwave balloon. I think I oversized my shockwave. Again, I tend to try to size to the distal vessel. I don't know, Chris, what do you do when
I just
shockwaving at a bifurcation, or do
I
you not even
oversize
think
them
it?
all. I'm
Okay.
kind of lazy, and I'm just like, look, it's 4 atmospheres. If this ruins the vessel past this diagonal, I guess so be it. I'll have to figure it out myself in a little bit,
Right.
and then I just kind of drag it back. Every once in a while, if it's a really big mismatch, it's like almost a dual LAD or something. I just pretend like I'm smart and I go to like 2 or 3 atmospheres instead of 4, and somehow that makes me feel better, which is
Oh, that's a
obviously
good
completely
trick.
treating me, and it's not
Right,
doing
right.
anything different to the patient. But I like to treat myself.
No, that's fine. And so I mean, yeah, you can see here, like this is I loved your, talk on pulse management. This is the opposite of that. I just put all 120 pulses right into
You managed it the way it needed to be.
yeah, well, unfortunately I still wasn't able to get it to expand even with a
That's fine.
slightly oversized balloon. So, you know, here's some of those. So this is what, when I laser, especially for balloon undilatables and stent, I tend to laser on full contrast at 80/80. I used to just do saline and maybe work my way up, uh, but now I just typically tend to start right there at sort of full bore.
Yeah, I'm with
Um,
you. I'm at 80/80 on contrast.
so, and at this point, I walked away from it. It was, she was getting a little uncomfortable on the table. I was now at my contrast limit. We typically use 2 times the creatinine clearance. We believe in contrast nephropathy. I know that's a hotly debated topic, but So I was
Well, you did a
running.
lot of work. I mean, I don't know that contrast or no contrast. I'm pretty sure I
Fair
would have been
enough.
like, look, I gotta go. I'm exhausted. This is too much.
Yeah. So interestingly, she felt better after this. It's
Yeah, I mean,
a
you got some relief of the lesion by a good bit. I mean,
Yeah, so
yeah.
I mean, it's better, but certainly, I met her in clinic. She said, "Yeah, I feel better. I'm still having some symptoms." And again, the idea is that she wants a durable result, which, I told her, I'm like, I don't know that anything I do is going to be durable here. This is some really gnarly disease you've got. In fact, that's the exact words I used with her. So she was asking about a minimally invasive redo cabbage, which I thought was cute. But what I said is, I think that if I can get your stent expanded better, I think that, by all studies at least, and, I'm pretty much quoting the IVUS trial, so ultimate, renovate, everything driven by stent expansion. I think that that's what's going to get us our best result, at least from a durability standpoint.
I think that
Although,
makes sense. I think that makes a
yeah,
lot of sense.
again, there was a lot of hedging in this conversation because I didn't know what the right thing to do, but we both agreed that this will probably be, the best way to go. And then, I was thinking, well, is there something I missed? There's something I can pull from the CTO world that may help me here. Not really. I was thinking, well, maybe, stent the subintimal space around it. But the main thing is I'm going to lose that marginal in PDA. So I think I'm committed to just getting this thing to expand. And so, yeah, last month I brought her back, and I don't do a whole lot of stent rotablation. I actually had just gone down to Kevin Croce's lab a few weeks before, kind of watching his techniques. The big thing that he'd emphasized was, cranking up the speed on the burr. I usually burr it somewhere between 170 and 180, depending how I'm feeling on the day.
Yeah.
For these, though, I turn it up past 200 to 210,000 RPM,
Yeah.
and then always trying to make it a point to reposition the wire because, certainly burring at that speed, you do run the risk of grinding down and cutting the wire.
I
I don't know
think
if you have
people
anything else you do.
should definitely heed your advice there. You really do have to move the wire, and especially at 210, you really decrease the amount of burr time you get. You know, in a regular burr and a regular piece of calcium, I don't know about you, but I generally think of 5 or 6 minutes of total burr time before the burr needs to be swapped out. And that's a lot of burring, but there's some times where that's just kind of what you do. In these, I switch the burr out a lot faster because I think the metal really wears the diamond grit down a lot quicker. And then you get a slippery piece of metal against a piece of stent, and you're in all sorts of trouble if it gets stuck. So I think that these are really, really important points that you've made here. So
No, you as well. So doing this, finally after 7 passes, I was able to get the bird across with, had the nice happy triangles on it. Didn't stall it out, didn't get it stuck. I know there was a great post last week on best way to manage burr entrapment. And so after that, we went back to shock waving it, and same thing. I put all 120 pulses in the lesion, and it's still not expanding. It looks better than it did on the prior attempt, but we're still not there. And so just to confirm it, I took a larger angiosculpt balloon, again, took it up to 35 atmospheres because, why not at this point? And it's still not expanding. You can see there on the right side, it just has that huge dog bone in it. And so I'm getting really frustrated, but now, there's no way I'm walking from this one at this point. So I upsized the burr, went to a 175 burr, which again, I don't typically use that. And then we don't have drug-coated balloons here. Well, we don't have coronary drug-coated balloons. I
sure.
can run down to our vascular surgeons and grab Rangers. And so if I wasn't going to be able to expand this, I wanted to give some sort of antiproliferative therapy. We're not a brachy center. And so I was going to shove a 4 millimeter Ranger across that to apply my antiproliferative therapy. Um, hopefully we'll be getting coronary DCBs in the future because they are a real pain to manage. They're just so stiff to deliver.
They are hard to deliver, I'll give you that.
I don't know. My go-to is to trade out for a Platinum Plus and over an 018 wire, and then desheath it from a 7 French guideliner. And a
Yep.
lot of times that seems to work. Anyway, so 5 passes, same plan with that 175 burr. And then finally, I just took a regular NC balloon and it cracked it. So got it to expand. Somehow
Whew.
that
It's a lot of work,
partial,
man.
it's a lot of work for a right corner. You don't even get the satisfaction of, oh, I fixed a prox AD or a left main. This is but we got it cracked open, and then I've started to, I pretty much I'm of the thought that most stents are created equal. Although for my ISR cases, I've started to lean towards ultra thin strut stents like Orsero's, um, especially for single layer ISR at this point. For multi-layer ISR, if I haven't ablated the stent away, usually I'll do a DCB. What's kind of your practice been?
Yeah, I just switch stent brands essentially. Not that there's
Oh,
any data for that. I just make that up in my head. But
yeah.
or somebody else made it up and I copied them. Who knows? But the short version is we use a lot of I use a lot of Synergy because we use a lot of Megatron, and
Hmm.
so I try and stick on one stent brand. That way, when if anybody comes back, or I'll go read people's reports or whatever, if it's in one of my partner's cases or some outside case, and then I'll just switch brands to something
Yeah.
else. Um, they're obviously essentially, in my opinion, I'm with you. I think they're all probably created equal. My idea is that maybe if the first drug was marginally somehow didn't work, the second one will work. Where I actually find myself contradicting myself is that the reality is that the rest of the stent did fine with the first drug. It was just that one area that didn't do well. So, like, what am I really talking about? So, anyway, I argue with myself internally about this, but I just switch brands. And for two
Gotcha.
layers, we just, like you, we fight peripheral drug coated balloons into position
Hmm.
and use them when we can. Sometimes that battle is not one that I win, though.
No, that's fair enough. Again, the idea is that usually it's, under expansion driving stent failure. So for the majority of cases, so imaging really just like, nothing outside the guidelines here. That's, very helpful. And so, I found that, a single tool here really wasn't adequate. And a lot of times, if you're going to manage these complex cases, properly, you have to combine a bunch of different modalities. And sometimes that does mean ablating the old stents that are there adequately. I prefer rotational atherectomy. I know some people will sometimes jump to orbital, but if you're going to allow the shockwave balloons to work, if you're going to be able to adequately expand this, sometimes you do just need to get rid of the stents that are there.
Yeah, man,
So,
I think it's a great case. It's a great example of essentially every technique in the world to try and deal with this, and a pretty impressive result, I got to say. And you kept that other branch, so all things considered, that's about as good as you could really ask for. You know, I applaud you too for stepping the burr up. I'm not sure if I would have thought of that in the sense that I don't spend a lot of time stepping burrs up anymore because I sort of use rotational atherectomy to deliver lithotripsy, and I don't do much orbital anymore anyway. But the I haven't really thought about stepping a burr up in a while, but you got to keep that in your toolbox. It really is an important tool to keep in your repertoire and really think about because sometimes that's what you got to do. So
yeah.
that was an awesome case, man. Thank you so much for doing that. I came across this thing. It was at TCT. It's a registry of sorts, which as we know, a lot of our calcium modification or registries, it's hard to run randomized controlled trials. It's even hard to, I don't know how if you're in any of the trials for shockwave or anything or any other calcium modification
No,
devices, but
we're not.
it's kind of hard to even get patients into these things because they have to be so restrictive with what they want you to do. But we got this thing. So it's 120 patients, or 120 lesions, 118 patients, essentially 120 patients in Japan. They do imaging and everything, which of course we kind of expect from Japan. And they want to know whether or not you can do kind of dual modification, meaning some sort of atherectomy followed by lithotripsy to like get a stent open and whether it's safe and kind of what you get out of it. They use OCT mostly in the study. They have the usual OCT calcification score, the one that Ziad and other people talk about a lot, greater than 180 degree arc, greater than 0.5 millimeters, et cetera. Somewhat not pertinent to IVUS, and that you can't really tell the thickness in IVUS, but similar stuff. So do you have some calcium? And essentially, the procedure flow was they did atherectomy after they were able to cross the lesion, actually, surprisingly, in like 2/3 of the cases with the imaging catheter. I guess OCT catheters are smaller, so maybe that's why, but I don't find that imaging catheters in any flavor are particularly deliverable, frankly. And then they did some atherectomy, and then they did some calcium scoring, and then they did some IVL, and then they put in some drug-eluting stents, and then they looked at it post, and then they kind of evaluated it from there. And I think the striking thing is kind of what I think you might expect, which is the same thing that you did, right? You started with a 1.5 burr. I start with a 1.5 burr. I think a lot of people start with 1.5 burrs. They use a little bit of 1.25 burrs. Not really my favorite thing. I'm always a little concerned that's going to get entrapped, and I don't love entrapping burrs. I'm the person who made that entrapment case on Rumor, so that goes. But anyway, I thought that was interesting. Sort of pretty standard for complex practice, I think, kind of in the repertoire of what we would expect. And then as far as the balloons go, they used a surprisingly small size balloons on average. They used a lot of 2.5 IVL balloons, which I guess maybe the arteries are smaller there. But I think to myself, 1.5 burr kind of is for a 2.5 to a 3.0 vessel, more or less.
No, most definitely.
That's a lot of 2.5 shockwaves. I'm not really sure what that's about, but they did it. And they got pretty good results. I mean, you can see they did atherectomy. They had no acute occlusion, no perforations. They had some slow reflow, not unexpected, I suppose. One person had a dissection. Okay, I mean, you have a wire across, that's okay.
Right.
Then they did some balloon angioplasty that were, obviously a tincture of time for the slow or no reflow. And then the dissection, was getting tacked up by doing balloon angioplasty probably. And then they post-stent, they pretty much had nothing really. They had one person who apparently had slow or no reflow, which is pretty impressive. They had pretty good freedom from MACE at 30 days. I mean, there's 2 people who had a periprocedural MI from a SCAI definition, but otherwise nothing to really note. And they had pretty good procedural success. And I was like, that's pretty interesting. And then they kind of showed, this is they wanted to show their results compared to sort of other calcium modification trials. And, they have better stent expansion than pretty much any of the other trials. Combo therapy, kind of interesting fact. They have good eccentrically expanded stents, which is important, right? I mean, we all are worried about or trying to figure out how to modify nodules and eccentric calcium all the time. So
right.
Maybe a little additive by being able to do both therapies. I don't know, but all things considered, I thought it was interesting. I mean, I think we all kind of think about this. I don't know about you, but I think about this as a strategy that I use in nodules and in really heavily calcified vessels that I can't deliver lithotripsy. But I do wonder if there's something to shaving off some of the calcium and allowing the lithotripsy to deliver deeper, because of course it attenuates at some point in the depth of the calcium, and I don't know what the official depth is, and I'd have to look at some sort of animal study probably to figure it out. But I think this definitely is at least thought provoking to me. I don't know. What do you think? You think it's just more noise or something
No, I
worth
mean,
thinking about?
I think what's really impressive is that these are all, complex patients by the fact that they're undergoing this degree of calcium management, and that safety profile is really impressive. I
It
mean,
really is.
take the rotoblator away, take, the balloons away. That's really impressive to have no major complications in this. And, I do wonder if the fact that, moving through the case, rotablating, and allowing for much easier delivery of your shockwave balloon is going to keep you from causing all the complications that come with all the strategies we use to just ram stuff down the artery and, the things that make our cases take a long time, leading to operator fatigue and all the other mistakes that come from it. I wonder if just, biting the bullet right away, going rotablating, deliver your shockwave, and then, image it and be done with your case after some stents, may actually simplify some of these complex cases
I think you're right, man. I really think you're right on that. I think that it does simplify the stress and the strategy and the, do I need a wiggle? I got to balloon this guide extension down here. I'm ramming everything everywhere. I'm trying to unsheath things. It's not going. I'm dissecting the proximal vessel because I'm ramming the guide extension. I'm losing the guide. The wire's coming back. All this stuff that's just, like you said, driving the fatigue. It's like, no, I'm going to cross it. I'm going to rotablate it, and I'm going to nicely deliver a lithotripsy balloon, and then I'm going to stent it. It's like, well, kind of sounds simple, doesn't it?
Well, I
Anyway,
mean,
I thought it was
yeah.
neat. So I just wanted to share it with you. But yeah, man, thanks again for your case. It was really awesome. We really appreciate you. We'll see you again on some more stuff on Murmur, and we're really happy that you joined us. And thanks, everybody. We'll see you next time.